Ahlers couldn't be here. She had an issue with a family member. But she sent her husband, the cop from Cincinnati.
Now, if you'll turn to page 7, she's much better looking.
So we have Bob Ahlers here, and so Bob's going to kick us off, and then I'm going to fill in some of Mary's slides, and then we'll get through the rest of the group of Kurt Bashford from General Devices, Dudley Smith from CAMTS, and Josephine Kershaw from Christ College of Nursing.
Good morning, and thank you for having me as opposed to my wife. I asked for just a couple of minutes. Gary has been gracious enough to do her presentation. As he alluded to, I am a police officer in the city of Cincinnati in the middle part of the United States. I know absolutely nothing about your world other than you guys do a tremendous job. And personally, professionally, I thank you. Mary could not make it today, and she looks forward to this all year long. She likes the interacting, she loves the networking, and she loves all the ideas that you guys come up with. Without any further ado, I'll let Gary give a good treatment of her presentation.
Thank you, Bob. Okay, so we have 2 or 3 different things going on with this presentation, but it's going to center a little bit around the education process and some work that's going on in terms of degrees. We have a language that we use and things that are important to us, but the public has sometimes a different language that they use, or the people that might fund us have a different language that they use. And so while we might think of treating and not transporting a patient as a good thing for the ambulance service, if we can reduce the number of transports we do, it also has a message with the community. It's keeping somebody at home who may have otherwise ended up in the hospital and spent several hours. So one of the things that we wanted to hit was a little bit about a process model of the community paramedicine. So first of all, there's identifying the occupation, then educational programs and training, professional standards established, a code of ethics, and societal support of the profession. So one of the things that happens when people use the curriculum that we provide free of charge to colleges, one of the first modules is all about getting into the community and doing a community health needs assessment. We fondly refer to those as CHNAs. And so when we think about the community, it's really the gaps in the systems that they need that we're trying to fill with community paramedicine. And that's why the programs are all a little bit different. Some of them are doing just work with 911 callers. Some of them are doing lots of primary care. Everybody's doing lots of social service activities. So one of the important parts of deciding to start a community paramedicine program at all is to do the needs assessment and have conversations with the community, map out the healthcare system so you can identify the gaps, and then try to fill those gaps. So the benefits of doing it are there's several parts. There's research of studying the agencies and organizations that serve the underserved and low income, tabulate and input and analyze their themes, issues, disparities, and gaps, identify the most serious health issues facing the community, and prioritize the health issues and determine the barriers. In terms of the community, they have several places where they interact. The healthcare systems have financial challenges. We've heard about that. We know what they're like in our world. Patient safety and quality are issues. Government mandates, personnel shortages, patient satisfaction, population health, emergency department overuse, and preventing readmissions. So any one of these might be part of a community paramedicine program, or a community paramedicine program might aim to address several of those issues. It just depends on what's happening in your community. What we do know, the most successful programs are collaborative, and they work with other agencies. We have lots of home care providers in the United States that wonder about community paramedics and if we're there to take over the home care business. But we've had some rural research actually published recently out of the University of Washington. And what it shows is in the rural community paramedicine programs at least, The home health agencies are referring patients to the community paramedics at about an equal level to what the community paramedics are referring patients to home care. So, once those relationships get established and the boundaries are known and people know how to access the other services, you can make those things sort of work. All right, we're going to switch now to Kurt.
Thanks. Thank you, Gary. Good to see everybody here. It's good to be here, especially because we're getting about a foot of snow at home, so it's really good to be here. I don't know that my wife would agree. So we're going to take a little bit of a left turn in the middle of this block of presentations where we're talking about pathways in education and such like that. And we're going to talk a little bit about the technology and technology for community paramedicine and EMS and such. So, med tech is certainly a driver in healthcare. Healthcare is advancing, healthcare is evolving, technology is behind a lot of that evolution. It was mentioned earlier, and we see it around the States, and there was mentioned about a stroke unit in Canada, and those are popping up, and I think that's an example of technology and things pushing out from the brick and mortar walls of the hospital. What can we bring out to the field? And certainly community paramedicine has aspects of that. But technology, wrong direction. No. Somehow we're mixed up here. There we go. There's an extra slide in there. So technology is easy, but sometimes the change aspects of it is hard and how we adapt. And while a group like this, in some ways, this is preaching to the choir, because by the nature of you being here and involved in community paramedicine, you are some of those that are on more the leading edge of advances and changes that are going on out there. But not everybody's on that part of the curve, on the adoption curve, and whether the disruption be a process and the change in the way we do something, or the disruption be a technology that changes the way we do something. So we look at the disruptive technologies is on the positive side of it as kind of responsive innovation. How do we apply a technology? How do we evolve? The barriers to that are, well, we've always done it this way. We're resistant to change. Our medics are trained. We don't have to, it's good enough. But then that hampers, that thinking certainly hampers. Some look to groups to see, where do we go from here? How do we push some of these advances? And like Ford said, if he would ask, the average person, what do you want? They would have said faster horses. And he came out with a car. When Apple came out with the iPhone, they didn't really do focus groups because they kind of knew that the average person would have said, yeah, we want a slide out keyboard and we want to pull out antenna, and that's all the advanced technology that we need. And they leaped across that. So it's around us, and it is in this evidence-based world. Technology needs to be adding to the value of the patient care and not detracting it, and not just a shiny object. Let's see if we can. Okay. So one of the things we look at when we're measuring, because you can get shiny object syndrome when you're talking about technology, right? There's new apps that come out and new gadgets, and they're interesting, and EMS is pretty creative on applying things, but does it really help your care? Is there synergies there? So if we look at it as, what's the why? Never mind what it does, what's the why? So I imagine mission statements and core purposes that you have in your agencies are probably some variant of that top line there. Advancing healthcare, doing more for your patients with less. Us as a technology provider, ours is along those lines. It's really to provide tools, and you need that alignment in the thinking and what it is. So a piece of that, and piece that we're involved in, is on the communication side. And sometimes we think we communicate better than we actually do. A lot of the communications in traditional ambulance care and EMS care is voice communication, sometimes text, sometimes data. But what is the context? What is the tone? We've all had those text messages or emails that we exchange, and they interpret very differently than you had written it, or expressed it. So, are we getting the messages across? Are we communicating? And with the community paramedicine, certainly there's needs to be able to communicate on patient care to a range or a variety of providers. It may not be the traditional, 999, 911, where you're talking to a medical director, to a hospital, but now you may be talking to a primary care physician or somebody else in the care continuum there. And being able to have that continuity is important. So it was touched on earlier. James had mentioned telehealth, and we kind of exchanged the terms, and they even a world that we live in, they get blurred a lot between what's telemedicine, what's telehealth, and depends on who you ask and what the context is. But there's technology to allow you to do things more remotely, and kind of along that concept. And I saw it up earlier. Right place. Right time, right location. How can you do that with working with less, right? So we mentioned everything is cash strapped, and you're trying to stretch resources and people and skill levels. So we're going to talk in the next pieces about education and skill levels, which we know are varied. What can we do to bridge that? Can we use technology to perhaps help in training, to help in mentoring and such? So part of the telehealth and telemedicine piece that's more appropriate for community paramedicine is the mobile aspect. And that's changed over the years. We've been involved in telemedicine, going back to the 90s, but things, like our mobile devices that we carry and the equipment that they carry on the ambulance, the game's really changed. Broadband, wireless. So what can we do with that? What are some of the applications? And there's standard, emergent type applications, and then certainly there's applications within the community paramedicine side of things. But it's all about, what's the option and what the need is from you. There we go. So on the CP side of things, what are the applications? What can be used? Where are the holes? Where are the gaps? What are your needs? Because that's really what needs to drive it. And again, it's not necessarily a technology solution looking for a problem. It needs to be that alignment of the whys. What is your mission? What is the technology mission? Is there alignment there? Can this provide pieces and fill some gaps that you have? Again, we mentioned the qualifications and doing more with less. Right care, right time, right place. So it's not just visual. It's not just voice communications. We're very data-centric. Some of the presentations here, you see modeling and statistics and measurements, but when we have other measurements and data from the field itself, right? So we have parameters that are coming out of the devices that we go into the home with, EKGs and blood pressure measurements and pulse ox readings, and some of this is on episodic basis where the medic may be bringing this into the home and taking a set of measurements. But there's also telehealth where there's devices left in the home for more of the chronic care. So whether it's a CHF patient or a diabetes patient, where they can use this to perhaps even trigger alerts. So if you got a CHF patient and there's scale readings daily and they see a spike in that can trigger an alarm and an alert. And again, allow the continuum of care to catch things earlier and not let this become a transport back to the emergency department. So it all comes down to, what are the results? What do you get out of this? Is it doing what you need? EMS and community paramedicine certainly are quite varied. You heard it here. We hear it all over the states. There's an expression, and I imagine it applies here. If you know one EMS system, you know just one EMS system, and that I sure applies with community paramedicine. Everybody's got a little bit different twist and turn, and there's really no necessarily right or wrong on those applications. The pendulum will swing, and what makes sense will stick, and what doesn't will go away. But is it getting the outcomes and the results that you're interested in? The gentleman pictured here is a medical director out of Baton Rouge, Louisiana. He works with his community paramedics, and he carries an iPad. So when they need to make a consult or contact with him, he can be in that mobile world and do a direct consult. And they can do it by information, they can do video, and that video may be between the care providers as a physician and medic, or that can be even in direct interaction between the physician and the patient itself in the cases where that makes sense. So it's all about that, and that's where we are looking and working with providers on what are the needs, what are the holes, what are the gaps, how can you use technology such as that to provide better patient care for your patients. So as we wrap up, we do have a white paper that you can download if you can get a little more information on that, or if you see me after, we can get you a copy of that. It's an evolving field. There was a stat that I just read. It said, and this is probably more in the hospital side, but again, you can see how technology is moving to the mobile environment. But on 2013, there was about 250,000 telehealth interactions with patients, or patients handled. The estimate for 2018, so looking ahead a year, was 3.2 million. So you can see there's a pretty sharp increase on what the prediction is and how this is. So just some takeaways. Changes all around us. It's nothing new to you. You're involved in it right here with CP. Telehealth and telemedicine is a tech tool that may be able to assist you in your programs and allow you to communicate in new and better ways, and we embrace that by what we term responsive innovation. And hopefully, thank you.
Thanks, Kurt. Good morning. I'm Josephine Kershaw. I'm the Associate Dean and Professor of Health Sciences at the Christ College of Nursing and Health Sciences. And I wanted to provide a visual bridge to the presentations that we have in this particular set of presenters. And so, couple of visual aids here. All right. I wanted to show you this first, and this is from the packets that were given to us from the AACE, a map. And the first presentation that we had from Gary, and Mary would have loved to be here, was to sort of give us a big picture lay of the land, like a map of the community for community paramedicine that we serve. And so we have general maps that have an overall view, and then we also go down to community maps, which show more of the resources that are in the community, perhaps even by street or by the various agencies that are available. And as an educator, I like to build those bridges and links, and our presenters who talked about their work in the community did exactly that in terms of bringing those resources together. And as community paramedics, that's the role, is to look at what's going on in that particular community so that those resources can be brought together. And then my presentation is going to next presentation was Kurt, and he talked about the tools, and most of us here who came from other countries flew or took other means of conveyance, and so the tool is like the plane or a bus or a bicycle or a telephone that allows us to reach out to the community. And those technological tools, especially now, can allow remote as well as more interaction between various parties that can help to improve the patient experience. And so my contribution to the presentation is to provide the educational pathways for those who are in the community paramedic field to advance in their profession. And it'll be followed by Dudley's presentation on now that we know where we're going, are we doing the right things to get there? So my presentation, sort of linking it back to what the travel mode, that we're all on a journey here. So my presentation, and happens to be I flew in Iceland Air. It shows the different routes that they have towards the destinations that they offer. And so in the educational pathways, we have in our different countries many ways for the profession or people who want to enter the profession to get in. And there were also questions about, once those who are already in the paramedic field or the EMS field, what to do in order to be credentialed or board certified, or the different terms in qualifying for community paramedicine and providing those services. And that's part of the professionalization of community paramedicine. In the slides that Gary mentioned, the first one was the process model where the definition of the profession was needed to be done. And so defining the profession also progresses so that you're allowing those who are in the profession to move up through the career pathways. So in this particular model, and Gary had alluded this to us in his initial introduction, at the entry level, there would be the community paramedic technician, and this awards the certificate or technical diploma. And here you can see the various roles that this entry level practitioner can do, and they function under the guidance of an advanced care provider, whether it's a physician or an advanced nurse practitioner, etc., to provide for the needs of the community. Okay. The next level is the associate's degree, and this is at the clinician level, so this would be a step up from the technician role. So the community paramedic clinician would add the capability of conducting physical examinations. The next level is at the bachelor's level, and with the bachelor's degree, you would receive the designation of the community paramedic practitioner. And here, the additional role that the practitioner is able to conduct is to modify and to create and develop a treatment care plan, again under the guidance of a medical or advanced provider. The next level up is with the master's degree, and with the master's degree it would be the advanced practitioner, and building on the previous skills. It's similar, and I'm going to make the bridge as well to the other professions for how these various levels of career pathway would apply. So there's increased autonomy as you and training as you go up through the levels, and here it shows that the certificate or the entry level, the PCT, the patient care technician, that's comparable in the nursing field, since I'm in a nursing school, to the licensed practical nurse, the EMT, as well as the community health worker. At the associate's degree level, this is the primary care clinician, and here we see that there are other professions that have certifications at that level. Also at the bachelor's degree program, we have the practitioner level, and that would be comparable to the occupational therapist, the RN, etc. And then at the master's degree program, we have then the nurse practitioner and the licensed social worker. So showing how in other degree programs and career pathways, it has a progression, in the same in community paramedicine, that can also occur. And then hopefully in the future also the doctoral program that would be comparable to the MD and the DO, et cetera. So there's a whole progression across the continuum. And I know in different countries that there are different pathways to do so. In the US, it's not as defined, and so this provides a pathway for those who are in the profession. And with the International Board of Specialty Certification, John Clark's presentation, hopefully that will provide a bridge across countries that will allow standardization so that those in these different levels of the career pathway would be able to progress with the certification exams. And here, this provides the linkage to the IRCP's designations for the different titles. So in this slide, the various roles of the community paramedic are defined. And again, since I'm in nursing school, looking at the roles of a nurse and how they parallel those of the community paramedic. And all with the goal to improve patient care, to provide services that are linked across the continuum within the community so that our patients and those our clients are able to access them. So the career pathways that I've shown, we've started with the standard definitions of the community paramedic profession as they move up the levels from the entry-level technician to the clinician to the practitioner and advanced practitioner. And this is done through coordinated educational curricula that is substantiated by the accreditation and process for taking the certification exams. And it'll be supplemented as well with the next presentation by Dudley on now that we know where we're going in our educational pathways, how do we make sure that those programs and those practices are being done correctly? And then all towards the goal of service reimbursement and legal recognition so that the services that are provided will be recognized through policy and given the appropriate credit and payment so that they can continue. We gave a somewhat similar presentation at last year's IRCP in Canada, and just to give an update, at the Christ College, we were approved by the Higher Learning Commission, which is the accrediting body for education institutions in the Midwest, to have Associates of Science and a Bachelor of Science degree in Health Administration. And so we have a community paramedicine track, which we've worked with Mary Ahlers, who's our first presenter, to ensure that those skills for community paramedics would be in that community paramedicine track. Also, another institution that was, and it's all about partnerships. As you know, with working in the community, it's all about partnerships. Another partner that we have is the Hennepin Technical College in Minnesota, and they have an advanced community paramedic training program. And so we've worked with them to have an articulation agreement so that those credits transfer directly into both the associate's and the bachelor's degree program. And there's a seamless continuation towards the career pathways from that organization. And so with that, I'm going to hand the podium over to Dudley.
The way that I kind of look at some of this stuff that we've been talking about is you have to start off someplace, and when it comes to things like community paramedicine, you just don't take a seed, put it in some water, throw a bunch of fertilizer on it, and end up with a paramedic. They have to go through a progression, and they have to learn what they're doing. So they have to be selective in who you get. You have to put them through a training program, and that training program really needs to be a training program that somebody's looked at and said, this is a good training program. So there's usually a process that sets standards and sets credentialing for the training programs. Then the people that graduate from there can walk out with a certificate that says, I've done something that's a standardized process of education. And if they are really good and they've gotten additional education, then they can go to an organization like John's and prove that by going through a certification process that says I can demonstrate the fact that I am competent in doing what I'm doing. So they can advance in that process. The part that I'm going to talk a little bit about is the Commission on Accreditation for Medical Transport Systems, and give you a little bit of history about where we are and why I'm here. But the whole process that we've just talked about has been more concentrated on the individual people. And what I want to talk about is the system itself. And that's what the Commission is all about. Commission on Accreditation for Medical Transport Systems actually started back in thought process in the late 80s. And part of the problem is, particularly in the United States, there was a high level of helicopter crashes, hospital-based types of helicopter crashes, because there was no real good standardization. And as we started looking at overall safety and the ways that we can improve that, we also said, you know, there's no standardization in the way we do medical care either. And one of our medical directors on the board at that time said, you know, we're probably killing people in the back of the helicopter, one patient at a time, that's never making the news, more so than we are from a helicopter crash where you're killing 3 people, just because there's not any standardization in what we're doing. So the commission began in 1990, and the way that we did that is we pulled together representatives from 6 different organizations, national organizations, the flight nurses, the flight paramedics, and I'll show you a couple other ones in a second or two. But we brought those people together to talk about how we can establish standards that everybody that would agree upon. Over the last couple years, the last 2 or 3 years, we've also have expanded. We now have about 190 programs that are accredited throughout the United States and in 6 other countries. And we're getting more and more interest on an international basis. So that's one of the reasons that I have both logos up here is last October we opened up our Zurich office with CAMTS Europe. And the CAMTS Europe standards are very, very much based on what the United States standards are going to be, but they're a little less Americanized and a little more European. And if you're either one of those, you'll probably understand what I'm talking about. The board of directors right now is made up of 21 different representatives from 21 different organizations. So each organization that is a member of the CAMTS board picks the person that they want to have represent the organization. Once they step onto our board, they no longer really represent that organization. They represent CAMTS, but they're the conduit back to that organization. So on there, you'll see some names like the Aerospace Medical Association. The medical director for that is a physician. He was a flight physician at a helicopter, emergency helicopter-based program in the United States, hospital-based program. He also happens to be the medical director for the International Space Station at the moment. We have organizations on here like the American College of Surgeons, the American EMS Physicians Association, Emergency Nurses Association, the Paramedics Association, the Communications Group. All of those organizations have come to us over the years and said, we need to be part of the process. And so when we started off with only 6 organizations, all these other organizations have come and said, we need to be part of the process. And we've invited them to be part of the process, because the way that we look at this, these standards are not the CAMTS standards. These are the standards that were developed by the industry itself. And whenever we make changes to the standards, it's because somebody in a room like this came to us and said, you know, you really need to look at this, or we need to be stronger on this, or this doesn't make sense and we need to change the way that we're doing some of these things. In addition to the people that are listed up here, we also have 65 site surveyors. The site surveyors come to us with backgrounds with at least 5 years worth of experience in medical transport of some sort. They've been program directors, they're chief flight nurses, and we picked them based on their background and experience, and we always look for people that have got experiences in more than one area. So if they're coming from a helicopter-based program, then we want to make sure that they also have administration or quality management, those kinds of backgrounds as well. So they're the ones that we actually send out into the field to do field site surveys. And every program that we look at has a variety of components to it. There's a lot of review that we do on all their policies and procedures and their medical protocols. I'll show you the list of things that are included in the standards here in a second. But then we verify that by sending out site surveyors that actually go out and look at the bases, and they talk to the staff. They look at their policies and procedures. They look at the checklists and things that they use. And the whole idea is that we want to look at the entire program. We're not looking at just the aviational component. We're not looking at just the people component. We're trying to look at the overall program itself. In addition to the representatives that we have from all these other organizations, we also have 2 ad hoc members. And both of those ad hoc members happen to be, at the moment, specialists in safety. And not necessarily just aviation safety. We're looking at all kinds of safety, patient care safety, those types of things as well. The standards that we have are actually in the 10th edition. Here's a copy of the standards. If anybody's interested in seeing this, I'll have it around the rest of the conference here. And it's broken down into a couple key components. The very first part of this is management and staffing. And in the management and staffing process, we're looking at how well you're taking care of your own employees, for one thing. Do you have policies and procedures in place for them to follow? Is there an ethical business practice? Do you have time and fatigue management processes in place so that people are not out working 24 or 48-hour shifts and not being able to get rest? Because people make mistakes then, and that's how accidents happen, and we don't treat the patients the right way when those kinds of things happen. So we look at all of the aspects related to the business aspects of the program itself, which would include things like ethical business practices and board meetings and whether you're even meeting with your staff and those types of things. The next section is in quality management. Quality management we've broken down into 3 components, although they're all interrelated. The first one is related to patient quality care. And quality is clinical care, but it's also all the other components of this. And one of the things that we discovered, and one of the reasons that the CAMTS came about and we started looking at all these other organizations, is that we found oftentimes programs were very siloed. So the aviation component, people didn't talk to the clinical people, and the clinical people didn't talk to the maintenance people, and the communications people didn't talk to anybody other than sending them out to tell them where to go. And there was no good collaboration, and we wanted to break that down. So quality management, when we look at quality management, we look at the entire program. Are they looking at things like maintenance on the vehicles? Is there a quality process to make sure that those things are safe? The next part of this is utilization management. And this is one of the things that's changing between the European version and the United States version. In the United States, there's a lot of overutilization of air medical services in particular. And you heard a little bit about it earlier this morning, of the overutilization of ground ambulances here in the UK. So is anybody looking at that? And what kinds of things are we looking at to try and improve that? What's patient satisfaction scores look like? So is there a good management process about even things like lights and sirens? So are we utilizing the services the best we can? The way that I usually describe it is quality management is, of the things that you're looking at, are you doing them right? And the utilization part of that is, are we doing the right things? Should we even be in this kind of a business, or should we be doing these kinds of things? So is your program looking at those kinds of things? The next part of this is safety management. Do you have a safety management system, and what does it include? Are there ways for employees to report when they have a safety concern? And is there a follow-up process to make sure that the employee gets feedback on that, as well as how you solve that particular management issue or safety issue? So are all those kinds of components in place? So all of that makes up that quality management section. The next part in here is patient care. How do you take care of your patients? Now, one of the things that I didn't mention is back up in the management staffing, one of the very first things we ask for is the mission statement for the program. What's your mission? Why are you here? So the mission's going to change based on the kinds of things that you do. When we look at a program, we ask them, the very first question is, why are you here and what's your mission? If they tell us that their mission is to do pediatric transports and neonatal transports, then that's what we're going to look at them as doing. If their job is to do advanced life support type of services, we're going to look at them at that level. If they're looking at critical care transports, we're going to look at them at that level. But all the things that I've really talked to up at this point in time related to the standards apply whether you're doing very basic service, whether you're doing intensive care or critical care services, or whether you're doing community medicine. You still have to have those things in place in order to be a good quality program. Under patient care, one of the first things we look at is their medical mission. So it goes back to that mission statement, and also it looks back at their scope of practice. What kinds of people do you have and that you hire to provide those good patient care? And do they have the appropriate license? Do they have the appropriate training? We look at the medical direction. Is it a medical director who signs off on the paperwork once a year and doesn't know any of the staff? And all they do basically is look at the policies and procedures. We don't want to see that. We want the medical director to be heavily involved in the program. Are they part of the interview process? Are they looking at the overall training and orientation? Are they involved in doing competency verifications for employees, particularly for those high-risk, low-volume types of things? So we want medical directors that are heavily involved in the program, but we also want to make sure that they're qualified in order to do it. So if it's a neonatal transport service, for example, the medical director should be a neonatologist. If it's a BLS or an ALS service, then we expect the medical director to be sort of an emergency medicine type of a physician. So does the medical director match the types of missions and things that the program's doing? We also look at training. Their initial orientation. Are they getting the appropriate orientation in order to do a safe and good job? And what kind of training are we put them through on an ongoing basis? You can't just take somebody, train them once and send them out in the field and say you're good for the rest of your life. We want to particularly look at their continuing education and are they doing the right things, particularly on competency verifications and skills. Are we really going back and verifying those types of things? We look at equipment and supplies, particularly as they relate back to the mission statement. We look at infection control. Is there a mechanism for somebody to report when they have a needle stick? And is it a timely process? Can they get a follow-up that they need to get it when they need it? Do we have a policy in place for latex allergies? Do we have a policy in place so that somebody that's been exposed who may have been with somebody else that doesn't even know that they may be exposed, is there a mechanism for them to get notified that they had a potential exposure there? We also look at the communications, and communications is not just the two-way radio communications. We're looking at all aspects of communications. Are you using telemedicine, for example? And if you are you using it appropriately? A lot of the communication stuff is just, are you talking to each other? Is there a mechanism in the beginning of a shift so that the ongoing shift receives a briefing from the offgoing shift about the day? How the vehicle worked? Is the equipment working okay? Is there anything I need to follow up on from the last shift? Is there some type of a briefing with the communications people about what's the weather looking like today? Are there any issues that are associated with our doing transports and things today? So communications falls in a variety of different ways. And then how are those requests handled? We look at policies and procedures that are associated with disaster action plans and post-accident incident plans. So if a vehicle's out and has a crash, who does what in order to respond to that? And does that post-accident incident plan actually include making notifications to the family members? And how do we support the family members when there's been somebody that may have been involved in a fatal or a serious crash? Do we support the family in getting in to be able to see their loved one when it's particularly one of our employees? The next couple sections in our existing standards are all associated with specific types of operations. So there's a chapter there for rotor wing service. There's a chapter for fixed wing service. There's a chapter for surface transports. So we used to call it ground ambulances, but now we're seeing boats and we're seeing motorcycles and all those kinds of things that are being used and going through the accreditation process. And we also have a separate section for medical escorts. So for people that are going on commercial flights that need a nurse going along, we do accreditations for those as well. So why are we doing all this? Because people have come to us and said we need to do this. And we think that we have the structure in order to do this. And in particularly when I was talking with Mary and some of the other organizations have come to us and said we need to be part of the process. And one of the groups that came to us is the community paramedicine groups have said we need to have a process that looks at us as well. And a lot of these components are already there. The standards are already there. We just need to make sure that they get modified. Excuse me. We also provide some support. I'm going to grab a glass of water. Try and talk over that so you can still pick it up on the microphone. We also provide some support through the CAMTS process with some other publications. We have a thing called the Best Practices book that gives examples when we go out and do a program review. We'll pick out best practices and make those available for programs that are struggling on trying to figure out something. We have a textbook on cultures of safety, because one of the big issues is how do you develop a safety culture within an organization like this. We have a self-assessment compliance tool so that somebody can actually measure themselves against the standards. We also use that as a process for looking at grading the program when we go out and do the site surveys. We do some consulting services for programs that are trying to figure out the best way to do things, or we can go out and do a mock survey if they'd like us to do that as well. And we provide some workshops on how to prepare for accreditation and how to do things like quality assurance and quality improvement, those types of things. So why am I here? We're in the process right now of going through ANSI accreditation. We are a member of ANSI, which is the American National Institute for Standards. And we're one of the members of that. We've applied to become a national standard setting organization through that particular group. And I was hoping that we would receive word that we've gotten that accreditation before I came to the meeting today, but it should be hopefully within the next week. and basically what they do is they accredit accrediting agencies. And they look at your process to make sure your process is fair and an honest process. And organizations such as the National Fire Protection Association, Underwriter Laboratories, those kinds of organizations have gone through that particular process. So hopefully we're going to do that. But one of the things that we have to do, and as I mentioned earlier, our standards are your standards. You're the ones that tell us what to put into the standards. And that's not going to change. The one thing that we do need to do, though, is to establish a standards committee that's a little more formal than we had in the past. It used to be we just open up a room and ask anybody that ever wanted to give us any comments on standards to come in. We'll still be doing that. But now we have to have a more formal process where people are actually going to vote on the standards besides just our board members. So we're in the process of going through that right now and looking who's going to be put onto that standards committee. And it'll be a consensus group. I would encourage anybody in here that would like to be part of the process to let me know. I have some forms here that you can fill out a form, give me your email address and stuff, and we'll put you on the committee. No questions out. I'll make sure that you're on that committee. And you'll help us write what the standards look like. And then you'll vote on those standards. Once we establish what those standards look like and the standards committee approves those, then they'll go to the CAMTS board for ratification. We'll publish those standards, and then anybody that wants to can take the standards and look at them. I tell people all the time that the value is not the certificate that you get at the end of the process. The value is going through the process. And if you can actually take these standards, if you're doing medical transports and measure yourself against these standards and you think that you're in substantial compliance with these standards, we've done our job. But why not have somebody else come out and look at it independently and see if you meet the standards, and if you do, get recognized for the fact that you do. And more organizations are starting to recognize the importance of the CAMTS accreditation. We currently have 9 states in the United States that require this as their minimum for licensing within the state. A lot of insurance companies now only require or will only reimburse based on the standards, and a lot of companies like the federal government in the United States and some Indian Health Services, those kinds of things require accreditation now. You had some more? You want to wrap up? Or? Yep. Then we'll take some questions.
So just to wrap up the 4 presentations, back to the first presentation, that in order to be successful in community paramedicine, we need to know our community. So there should be a comprehensive community health assessment that is done specifically for the program that's providing those services, and for the community to find out what is available and the needs as well as the gaps and strengths of that community. And then designing the program to fill those gaps and needs as defined in your community health needs assessment. And in the prior presentation, the 3 things that were mentioned were delivering the right care at the right time and the right place. And in the U.S., a lot of times there's reference to something called the triple aim from the Institute of Health Improvement, and that's a slight modification where when this has been mentioned as well before today, to enhance the patient experience and outcomes, as well as to improve population health, and another thing across the board, to lower costs. So these will be very much in keeping with community paramedicine and what the objectives are of the profession. So in the slides that I'd shown, it shows how the community paramedics can work within and be an extension of the healthcare system to provide that coordination and lowering of costs and improve patient experience, deliver continuity of care, and improve community health. Then the last slide here shows the partners. And again, as I mentioned before, community paramedicine is all about creating partnerships within the community to provide for the needs of the members. And I just wanted to mention some of these were already mentioned today in the presentation. One that wasn't mentioned was the Community Paramedicine Association and Registry on the far right, and that provides it's a new organization. We worked with Gary on establishing this to make sure that there is this registry of those who are in the community paramedicine field, and perhaps you'll speak more towards that, Gary, but we're working in partnership. Those who are here presenting together are part of this organization so that we can have a coordinated effort to advance the community paramedicine profession and talk about both the delivery as well as the quality of the services that are provided. And here's our contact information.
All right, thanks. We're going to have to move on to the next presenter. As Pierre comes up, I wanted to say that you've now heard what the third world country of paramedicine is. And the United States is the only English as a first language nation